Well, I think we should start, don't you? Welcome to Columbia, and welcome to AIDS, Improving the Odds. I'm Richard Carlson. I'm the director of the Columbia Health Service, and I'm going to be very brief. I'm very excited about this turnout, and I think this turnout speaks the importance of what we're here to listen to and to talk about tonight. The people that put this program together are the Columbia Gay Health Advocacy Project, of whom Laura Pinsky and Paul Harding Douglas are representatives and sitting on my left here. Well-deserved hand. Laura is the founder and the advisor to the Columbia Gay Health Advocacy Project, and she works in the health service as a psychotherapist. And Paul Harding Douglas has been an AIDS educator on campus for a couple of years. They are together the authors of the famous Columbia Handbook on AIDS. This is the Simon & Schuster edition. There's also the slightly larger free edition, which is circulating in the audience here. I think Paul and Laura and the Columbia Gay Health Advocates have been very successful on campus in a couple of ways. In a macro level, they have kept the very complicated subject of AIDS, ARC, HIV infection in front of the university, writing this book, serving on the Columbia Ad Hoc AIDS Committee, and constantly being the strongest advocates you can imagine for a reasonable university policy on AIDS and a thoughtful policy on AIDS. They've also succeeded at the micro level in terms of individual students and individual staff members. So within that range, I think they've been very successful and continue to work very hard, and this conference is an example of the kind of work they can do. We have a lot of speakers tonight, and we're going to pack a lot into one evening. So I don't want to really speak any more at all. I'm going to introduce Laura Pinsky, Paul Harding Douglas.
If we had known what the lighting and temperature conditions were like, we would have suggested bathing suits and sunglasses, so sorry. We want to say thank you to the Columbia Gay and Lesbian Alliance and the Columbia University Health Service for providing funding to partially sponsor tonight's program. Estimates are that 1.5 million Americans are infected with HIV. Many experts agree that one of the brightest hopes for the future is early treatment of HIV infection before the severe damage of the immune system that's typical of AIDS. In the past year or two, several treatments for AIDS infection have become available, either officially or through the AIDS treatment movement. In addition, the current state of knowledge indicates that there are strategies for general health care that may help individuals preserve immune competence and that may indicate when treatment for HIV infection is appropriate. The purpose of tonight's panel is to hear from a group of top-ranking experts who can help begin to sort out these complex issues. The structure of tonight's program is that we're going to be dividing it into more or less 4 parts. In the first part, 4 panelists are going to speak about some treatments that are available at the present time. After that, 4 other panelists are going to speak about general issues in preventive health care for people who are HIV infected. After that, John James from AIDS Treatment News is going to be talking about prospects and obstacles to the development of treatment for AIDS. And after a short break, there are going to be questions and answers. One thing that people have said to us is that we had a lot of nerve to invite such top-ranking experts and then give them only time to each speak for about 15 minutes or so. And in a way, that's true, but the reason we did that is that we felt that it was important for the audience to hear a variety of viewpoints and to hear a discussion among people with different points of view. So this is partly by way of advance apology because we're going to be ruthlessly interrupting people as the evening goes on to manage to fit everything in. We also want to say that we know that in the audience there are both healthcare providers and people who are here because they are concerned about their own health and that of friends. And we are going to ask the panelists to know both that they're addressing a very sophisticated audience, but when they are using medical terminology to try to define it as much as possible. This, of course, is typical in a way of what's gone on with AIDS, where patients themselves have had to become experts in the disease in order to take an active role in their own treatment.
Okay, I'd just like to introduce the panelists and a very short description of their affiliation. If you want their full titles, you can look on these buff sheets that were available outside on the table. I'd like to start first with Dr. Barry Gingell, who's from the medical division of GMHC. Next to him is Dr. Bernard Bihari from the Kings County Addictive Disease Hospital. And going around again to the left is Dr. Daniel William, affiliated with St. Luke's and founder of the New York Physicians for Human Rights. Dr. William and his assistant Bob Friedman have also been a great help to our group over the past couple of years, and we'd like to take this chance to thank you for that. To his left is Dr. Joe Sonnabend, who is a pretty well-known AIDS practitioner and researcher. I'm sure he needs no introduction here. Obviously inspires great affection among his patients. Here from San Francisco is John James, who is the publisher of AIDS Treatment News, and I think that what John has to say tonight will be very, very interesting. Then Dr. Donald Armstrong is here from Memorial Sloan Kettering Hospital. At his left, Dr. Michael Lange from St. Luke's again. Dr. Jeffrey Laurence has come from the Cornell University Medical Center. Then Dr. Richard Keeling, who is chair of the Task Force on AIDS of the American College Health Association. And Michael Callen has come to represent the People with AIDS Health Group. Finally, we have Dr. Don Kotler, who is also affiliated with St. Luke's Roosevelt Hospital, who is a great friend of the gay health advocates. He and his assistant, Anita Tierney, have been incredibly generous with their time over the past 2 years, and we'd just like to take this chance to say thanks a lot, Don. Okay. We're going to try and talk straight through and take a break around 10:30. My watch says it's about 8:10 right now, so we're going to have to speed right along. Because of the time constraints, we are not going to have direct questions from the audience. What we would like you to do is write out questions, hand them to anybody with a staff badge on, and we will go through them during the break and try and ask a representative sample of questions. I'm sorry about this. It would be great if we could have direct access, but it's just a matter of limited resources. Okay, we're going to start. The first section is going to talk about some current treatments for people who are at high risk or who know they are HIV infected, but who are not diagnosed with AIDS. 4 physicians are going to speak each for 10 minutes, and at the end, we'll spend about 20 minutes in sort of general give and take discussion among the panel. We asked each physician to cover the basics of the given treatment. What is the substance? What is the theory on how it works? What data are available on efficacy, side effects? Is the treatment generally available? And if so, where and at what cost? I'd like to start by asking Dr. Laurence to talk about AZT.
Since a lot of people are going to be talking about HIV and throwing out a lot of drug names and medical terms, let me just give a brief introduction of the virus and then talk about how AZT is supposed to work. The HIV virus is small, but it's not that small. It's about 2.5 times bigger than a hepatitis B virus. It's roughly spherical. It has a protein coat. It pulls lipids off a cell once it pops out of a cell, so there's a lot of fat in this virus as well. And there's a fair amount of sugar. About 50% of the covering, or the outer envelope of this virus, is sugar, which intrigues a lot of scientists that look at inhibitors for attaching sugars onto cells as a potential therapy. The virus attaches to specific receptors on cells. Unfortunately, these receptors are present on lots of cells. They're present on T4 cells, important cells in the immune system. They're present on macrophages. They're present on certain cells in the nervous system. There's some experimental evidence that they're also present on some cells that line the intestine. Once the virus gets in and starts uncoding, and this takes about 20 minutes from when a virus hits the surface of the cell, its genetic material, which happens to be RNA, is extruded out, is copied by an enzyme called reverse transcriptase into DNA. This is another enzyme, RT, that you're going to be hearing a lot about, because AZT works at this level of taking some virus material and converting it into material that will integrate into the host genetic material. So you've got binding of the virus, you've got conversion of the virus into something the cell can use to subvert its own machinery. And then the virus starts using the normal cellular enzymes to start making more virus protein in preference to a lot of normal cell proteins. So a lot of the housekeeping functions of a cell start getting lost when the virus starts wanting to make more virus. Virus proteins then get made off of this genetic information that the virus puts in. These proteins get assembled into this nice little spherical package, and the virus buds out the other end. And that entire process from a virus hitting a cell to popping out more virus takes between about 6 and 8 hours. Now, I've been asked to talk about AZT and how might it work. AZT is what is known as a nucleoside analog. That means that it kind of fools part of the cell's machinery into thinking that this drug is part of a normal piece of genetic material that ought to be incorporated into genetic material. The hope is that it's incorporated by the virus, preferentially over incorporating it by the cell. This material has to get trapped inside a cell, so there's cell enzymes that put on extra chemical groups and traps it inside through a process known as phosphorylation. And what it does is it prevents you from adding on more building blocks onto the virus's genetic information, so the virus basically stops working. It's known as a chain terminator. And that clearly happens in the test tube, and that's apparently the mechanism for how this drug works in the test tube. Now, the side effects of this drug, well, first of all, what are its efficacy? There was a large study in 12 centers that's become quite famous now. Our center was one of the 12. 281 patients were treated in a blind fashion against a placebo. And it was found that in a 4.5-month trial, that the numbers of patients who reported feeling better, the number of people with AIDS who gained weight, the number of people with AIDS who increased their numbers of T helper cells, the cells that you want to work for you in the immune system, were dramatically different than the people that received the placebo, to the point that it became unethical just to give people placebos anymore, and that trial was stopped. It was then opened up to more people, and obviously people that had been continued to be treated with this drug. After about 6 months, curves started meshing so that you had individuals whose T cell counts were going up and up and up, and after about 6 months they started going down and down and down on average, to a point in which they equaled the equivalent of what they were before they started this drug, and sometimes lower. The main side effects of this drug in most people are effects on the bone marrow, effects on normal blood forming cells. About 1 out of 3 people will become anemic. About 1 out of 4 to 1 out of 5 people will lower their white blood counts. And sometimes the white blood counts go down to levels that are so low that you need to stop the drug or lower its dosage below a level that you're confident that it's doing something to the virus. If you ask, what does it do to a person's health? We forget about the fact that some people feel better, some people are going back to work. Does it really have an effect on your life? The only way that we can really answer those studies now are for the original group with pneumocystis pneumonia, and then it's just the statistic. If you say statistically that individuals who were not treated with this drug were living on average of 9 months, then it added 6 months of life on average onto that initial group. That doesn't sound terrific, but if it's your 6 months of life, it's spectacular. Obviously, something better is needed than that. I've been asked to talk about, okay, that's fine for people with pneumocystis pneumonia. What about everyone else? Clearly, there are a lot more people that are just infected with this virus that feel great and look great and don't even know that they're sick, or maybe starting to get some sort of symptoms, but don't yet have a disease that would put them into a classification with AIDS. And it's not clear. The government is running a study of upwards of 1,800 people that are infected with the virus, that have low T4 counts, and are asking these very questions. Specifically, if you take a population that is infected with this virus and say, what is the risk of developing AIDS within a certain period of time if your T cell number is 200 or below 200 or 400 or above 400, you can look at a table, and based on the multi-center AIDS cohort studies, come up with a number, but this is a very gross number. If you want a percent, individuals that have less than 100 T cells, 60% of those individuals, according to the Pittsburgh multi-center AIDS cohort study, will develop AIDS in 18 months. It's a big number. You want to do something about it if that were you when you had less than 100 T4 cells. The question is, should it be AZT that you should be taking? We don't know. Logically, it might make sense if you're helping people that have had pneumocystis and you're adding a certain amount of time onto their lives, that it ought to be tried in those patients, and it is being tried. A lot of the data are not out yet. In terms of individuals that have Kaposi sarcoma, there have been several large studies. There have been minimal effects just on the Kaposi sarcoma. Some people, lesions clear, and most people it doesn't. In terms of what it does to their T4 cell counts, not a lot. And you'll hear later about different ways of actually measuring virus in the blood. There is a method called antigen capture, in which in some people you can directly measure viruses floating around in the blood, and you can decrease the level of those viruses somewhat on AZT, but it's short-lived. So we don't even really know that we know how it works. You can't say there's a direct correlation between the amount of the virus and how this is working. Another problem is what about the other kinds of side effects with AZT? Well, outside of bone marrow depression, the drop in blood counts, which is the big deal, there are a lot of other kinds of side effects. Headaches seem to be a big deal in a certain population, but there were a fair frequency of headaches in the placebo group initially as well. This drug does cross the blood-brain barrier. It can apparently infect viruses there, and in a certain small number of people that have had neurologic problems related to this virus, they appear to get better on AZT, and that's good news. There is a problem with potential cross-reactions with other drugs, including common things that people take all the time. This drug is broken down in the liver and then gotten rid of through the kidneys. If you have a liver problem or a kidney problem, you may need to adjust the dose. The proteins in your body, in your liver, that metabolize this drug are proteins that are also affected by certain common things like aspirin and Tylenol. In fact, if you take, it's different in different people, but people who are taking lots of aspirin and lots of Tylenol may have more AZT sticking around. You think, well, that sounds like a great idea. The trouble is it's not, because it can start affecting your bone marrow, so you need to watch that. A real scare came up, and a real reason for letting your physician know what you're taking and not going ahead and trying 25 different over-the-counter and under-the-counter therapies for AIDS is that in a paper in Science a few months ago, it was discovered that if you add AZT on top of ribavirin, another drug that has been used in the treatment of AIDS, a much less efficacious drug, you actually block the beneficial effects, at least in the test tube, of the AZT by taking ribavirin. We don't know how AZT will work with other drugs. We do know in the test tube that AZT seems to work wonderfully with a drug that's used for herpes, known as acyclovir. And that at least in the test tube, if you want to kill the same amount of virus, you can decrease the dose of AZT, which might be good news for your blood count, and add a smaller dose of acyclovir, normally used against herpes, and kill the same amount of virus. Whether or not this is going to work in patients, we don't know yet, and there are trials of that going on. And finally, there's a question here. Is there evidence that the early use of AZT may limit its side effects? It's known that the better condition your body's in, the better condition your blood is in, specifically your bone marrow, the better you'll be able to tolerate it. So if it's learned that it's important to take this drug early in HIV infection, and I must emphasize we don't know that, then it would be better to take it when your body's in better condition, i.e. early. Stop there.
Thank you very much, Dr. Laurence. The technical people have asked me to ask that the panelists, when you're going to speak, pull the microphone closer to you and speak directly into it, and that way we'll all be able to hear without feedback. I'd next like to ask Dr. Donald Armstrong to describe aerosol pentamidine.
Pneumocystis carinii pneumonia is, which I will subsequently refer to as PCP, is the most common life-threatening opportunistic infection in patients with AIDS. There is so far no documented safe and effective prophylaxis for this infection. If PCP could be prevented, mortality, morbidity, and what would please or administration's medical costs could be reduced. Treatment of the infection is costly, facilities for its diagnosis and treatment are relatively scarce, and the number of people at risk is obviously increasing. The principal objectives of our studies were to determine the safety of aerosol pentamidine. Because the study population was at high risk to develop pneumocystis carinii pneumonia, the trials provided a preliminary basis for comparison of the effectiveness of at least different regimens of the aerosol pentamidine. Pentamidine is a chemical that has been used in the past to treat African sleeping sickness. It is an effective anti-parasitic drug. And it was the only drug with which we could treat pneumocystis carinii 15 years ago. It is a relatively toxic drug, and we know from studying its distribution in the bodies of both laboratory animals and of humans that it is concentrated in the liver, the kidney, and the spleen on intravenous administration first. And where we want it is in the lungs. So it seemed reasonable to use this through an aerosol or inhalation technique. The drug is toxic to the kidneys, and if we could use it by inhalation, then it would presumably spare the kidneys. So we first tried this in an animal model in rats, and found that it indeed was not toxic to the kidneys. It was concentrated in the lungs. It was not only concentrated in the lungs, but it persisted over days, and after multiple doses, even after months. We also found that it worked in the animal model, that it not only was effective for treating pneumocystis carinii pneumonia, but it was effective in preventing the development of the pneumonia. So on the basis of the animal studies, and we studied the animals very carefully for any signs of toxicity to the lungs, and did not find any. On the basis of those studies, we elected to undergo a clinical trial with appropriate informed consent. We have now been conducting these clinical trials for 18 months. A total of 3,567 doses have been administered to 215 patients. 2 treatment schedules have been used. Treatment has been administered either bi-weekly from the outset, or has been administered weekly for 4 weeks and then bi-weekly thereafter. 3 different doses have been administered. And this is a classical, what is called a phase 1 study. You start out with a very low dose, which you are confident is not going to hurt anybody, and then you build up, watching very carefully for any evidence of toxicity. And we've used 2 different methods of delivering the aerosol pentamidine. They're handheld nebulizers. With the rat studies, the rats had very little choice. They were placed in a bell jar, and a lid was put on it, and the aerosol was then infused into the bell jar, and that's all that they could breathe. Aerosol has been used for years. Aerosols have been used in order to deliver asthma medicine, for instance. And people just breathe the medicine in, and they can actually control the delivery of the medicine. And with one of the machines, they could actually turn it up and increase the delivery. So we tried 2 different nebulizers and found that they're called nebulizers, the aerosol machines, found that one was better than the other in that it was distributed more efficiently throughout the lung. Safety was judged based on frequent medical examinations, pulmonary function studies. We would do tests of the ability of the lungs to inhale, to absorb oxygen, and various other tests of lung function. No serious adverse reactions have been observed in any patient, and I'm sure that those of you who are aware of this kind of thing picked up that word serious. There have been no changes in the vital signs or in pulmonary, hepatic, or renal function that were attributable to treatment with aerosol pentamidine. Mild bronchospasm, which is wheezing has been observed in 7% of participants in using the best aerosol machine. All of these individuals had had a history of asthma before and knew what this wheezing was. Bronchospasm due to the aerosol pentamidine could be relieved or prevented by treatment with an aerosolized substance called albuterol, which is used to treat asthma. Cough was seen during treatment of 16% of patients using the most effective method of delivery, and most of these patients had a chronic cough before treatment. And usually the individuals found that they could control the wheezing or the coughing merely by slowing down the delivery, which they control themselves in these handheld nebulizers. In our trial number 1, using the lower doses, we treated 60 patients over a total of 194 patient months, and we had 8 proven cases of pneumocystis for a incidence of 4.13 cases per 100 patient months. In the second trial, when we were escalating the dose, we treated 84 patients over 328 total patient months with proven cases of 10 for an incidence of 3.0. So it went from 4.1 to 3.0. In the third trial, there were 115 patients treated for a total of 590 patient months, 9 proven cases of pneumocystis carinii pneumonia for an incidence of 1.53. So we went 4.13, 3.04, 1.53. In the fourth trial, using the better machine and using the maximum dose which we have found that could be readily used, 60 milligrams, we had treated 172 patients for a total of 789 patient months. We have seen no cases of proven pneumocystis carinii pneumonia, and therefore the number of cases is 0 per 100 patient months. Now, this may seem, this may seem a little better than it actually is, because during this time, AZT was introduced, and some of our patients then, or many more of our patients at the end of the trial were receiving AZT, which may skew it. But we think that this is very promising, and so that we feel that when pentamidine is administered by inhalation, the major site of accumulation is the lungs. That systemic side effects are absent because delivery of the drug is limited to the target organ. That we think the regimen appears to reduce the incidence of PCP. Its effectiveness, however, must be proven in future controlled trials, and we can discuss them in the discussion period. Thank you.
Next, I'd like to ask Dr. Lange to speak about AL-721 and about imuthiol.
AL-721 is really not a medication. It is a derivative of egg yolk, and essentially what happens is that by a chemical process based on acetone, the cholesterol, which as you know is a very major component of egg yolk, is extracted. And what you're left with is a composition of 3 lipids, namely 7 parts in 10 of neutral lipids, 2 of phosphatidylcholine and 1 of phosphatidylethynolamine. It was first developed by Dr. Meir Shenitsky at the Weizmann Institute in Israel, and he demonstrated that a major component of lymphocytes, particularly of aging lymphocytes, is cholesterol. And as lymphocytes age and incorporate more and more cholesterol into their membrane surface, the membrane surface becomes more rigid. It was demonstrated at the Weizmann Institute at the time that exposing aging lymphocytes to this substance, AL-721, in a competitive way removed cholesterol from the membrane surface and made it more fluid. Hence, they call this process a process of fluidization. In 1985, Prem Saran and Dr. Robert Gallo's laboratory did some studies in the test tube and showed that this AL-721 substance had an effect on preventing HIV from growing in lymphocytes. The theory as to how it does that is that the membrane surface, as Dr. Laurence indicated, the component of the surface of the virus contains a tremendous amount of lipid, which comes or gets into the membrane as the virus buds from the surface membrane. The idea is that AL721 alters the membrane enough so that the virus will not, as well as the membrane